every part of vestibular migraine is messy. The messiest and the most complicated part is therapy. Why? The problem of vestibular migraine is that the ground reality about it is that there is absence of any definite treatment strategy for vestibular migraine. Why? Due to paucity of adequate and high quality randomized controlled trials on the therapy of vestibular migraine. And this is from a very recent paper, 2020 paper. Even now they are saying that there is a huge paucity of adequate and high-end randomized controlled trials on therapy of vestibular migraine. So until you have good high quality RCTs, how will you determine the therapy? Second is that the pathophysiology of vestibular migraine is not known with certainty. Current therapy is based on mere speculation that the pathophysiology of vestibular migraine is presumably the same as that of classical migraine. Now, this is mere speculation. We don't even know about it. And we presume that vestibular migraine is just the same as classical migraine. Is it true or is it wrong? Is it not true? We don't even know that. We don't even know whether vestibular migraine is an autonomous disorder with distinct pathophysiological features, or is it a sub-form of migraine that includes vestibular symptoms that we do not know for sure. And in case it is a sub-form of migraine, then what are the special features due to which some patients of migraine will show vestibular symptoms and other patients of migraine will not show vestibular symptoms. So until we know all of these things, how can you treat the patient? So treatment suggestions for vestibular migraine are extrapolated from knowledge gathered from clinical trials for classical migraine. So there is no good, dependable and reliable RCT or any workup on these things on how to treat vestibular migraine. Why? Because we don't even know the pathophysiology of the disease. We don't even know whether it's whether it's a separate disease or not. So with so many ifs and buts, don't expect that I can give you a very clean, clear-cut idea of therapy. This is where our science is, but then we'll try to make some sense of what is there. Because we get a huge lot of vestibular migraine patients. And today it is believed that 1/3 of all patients that come to you with recurrent vertigo are actually vestibular migraine. So just because we do not have the right type of research, you cannot say that I will not treat it. So you'll have to treat it. So let us see the ground realities and let us see what is the best that we can do, knowing fully well that our knowledge on this subject is not very clear now, and it is not evidence-based. Now, what are the goals of treatment in vestibular migraine? Number one is aborting an acute attack, which is called rescue treatment. Second is prevention of vertigo episodes, or at least reduction in frequency or intensity of the vertigo attacks by more than 50%. And what is most important is with the minimum of medication or with no medication. How can we reduce the intensity and the frequency of vestibular migraine? And the criteria is that the frequency and intensity should come down by more than 50%. This is the international criteria that the treatment is successful or not. Then improving the quality of life of the patient. And lastly, treating the comorbidities for vestibular migraine. So these are our 4 goals of treatment: aborting an acute attack, which is called rescue treatment; prevention of vertigo episodes, or at least reducing the frequency and intensity of the attacks by more than 50%, and that too, most importantly, with minimum medication or with no medication; improving quality of life and treating the comorbidities. Now, treatment of vestibular migraine, it requires a multi-pronged approach, 5 ways. One is aborting acute attacks of vestibular migraine. Secondly is lifestyle modification plus trigger avoidance plus physical exercise. These are the non-pharmacological ways. Then the pharmacological prophylaxis of vestibular migraine. Then there are certain nutraceuticals in the prophylaxis of vestibular migraine. And lastly, the treatment of comorbidities. So when you are discussing treatment of or management of vestibular migraine, we have to touch upon these 5 aspects. Let us go through them one by one. Most important is lifestyle modification plus trigger avoidance plus physical exercises. If you are very strong with this, with the lifestyle modification, trigger avoidance and physical exercises, then you may not have to use any medicines at all. So our primary attempt should be to stick to lifestyle modification, trigger avoidance and physical therapy. Why? Because if by this we can control the vestibular migraine, then we don't have to use the drugs, all of which come with a huge baggage of adverse effects. These drugs are either calcium channel blockers, or they're anti-epileptic drugs, or these are psychotropic drugs. So they come with a huge baggage of side effects. So we have to try and see how can we treat it without medication. And if we have to use medication, then with a minimum of medication. So that should be our goal in treating a patient with vestibular migraine. Now, let's come to non-pharmacological treatment, that means without using drugs, and they're extremely effective. Number 1 is lifestyle modification, and that consists of regulated, relaxed lifestyle, proper diet, avoiding foods which are commonly known to trigger migraine, adequate sleep and rest. Adequate, not excessive. If you are having excessive sleep, then that also can trigger migraine. So remember the word, the right amount of sleep. That means about 7.5 hours of sleep. Then avoidance of triggers like exposure to sun, late night partying, etc. Now, with the younger generation, this late night partying and all, this is extremely common. And not only late night partying, they all work for multinational companies, and where they are used to working till very late nights, and that is one of the strongest triggers for migraine. Then moderate physical exercises, especially vestibular physiotherapy. That helps in a big way. We'll come to that, how physical therapy and especially vestibular physiotherapy can help in migraine. Here again, the same thing, moderate physical exercise. Excessive of physical exercise will again trigger migraine. So there has to be a balanced amount of exercise. And lastly, stress management, reduction of mental anxiety and tension. So these are the lifestyle modifications that is essential in any patient of migraine. And even if you are giving drugs to the patient of migraine, any medicine that you are giving, you will have to ensure that these lifestyle modifications are extremely well followed. Then we have the second thing is the avoidance of food triggers which are known to trigger migraine. Some physical therapy exercises, this one. Then use of protective gear to lessen the photo and phonophobia. And lastly, neuromodulation. It is a new type of therapy. We will come to it in case time permits. If Dr. Ramesh Royal allows us the time, then we will also discuss a bit about neuromodulation. So these are the different types of non-pharmacological therapies: lifestyle modification, avoidance of foods which are known to trigger migraine, physical therapy, that is exercises, use of protective gear to lessen photo and phonophobia, and neuromodulation. Now, non-pharmacological, we have covered lifestyle modification. Now let's come to avoidance of foods known to trigger migraine. A migraine patient is expected to avoid frozen, canned or pre-packaged foods, chocolates, coffee with cocoa, cold drinks that contain caffeine, cheese, Chinese foods and potato chips which contain monosodium glutamate, pickles or preserves, any fermented products, red wine, peanuts, breads and other products that have yeast, processed meats, smoked fish, smoked meat products like salami, ham, sausages. The list is huge. Especially which is now not new, which is known but not so much highlighted, is that foods that contain histamine or increase histamine levels in the blood, they have to be avoided in all migraine patients. So foods that contain high histamine, like tofu, soya sauce, foods with vinegar, mushroom, overripe fruits, or fruits that cause histamine to be released from other foods like kiwi, lemon, lime, pineapple, plums, papaya, some beans and pulses and tomatoes, they have to be avoided. So anything that releases histamine or foods that will allow histamine to be released from other fruits, because histamine is dangerous in patients of migraine. And so remember that when you are treating a patient of migraine, be careful when you are using beta histine, because in case we do not know, but in case beta histine does actually increase histamine levels, be aware of it and don't use beta histine in patients of migraine. Then physical therapy, non-pharmacological protective measures, and neuromodulation. So avoidance of foods known to trigger migraine, these are the ones. But then see, I've given us such a huge list that you will think that what will my migraine patient have? What will my migraine patient eat? Well, there is a huge yes list also, and this is the yes list. So there are a lot of drugs, there are a lot of foods which the patient can have, and if you go to, there are different websites. One is known as Migraine Cookery, and then there is My Migraine Brain. So there are different types of websites where they have special books for preparing food for migraine patients and what migraine patients can have. These are the list of foods that migraine patients can have. Then the non-pharmacological treatment, the last part is not the last part, the second last part is vestibular exercises. Physical therapy, especially vestibular exercises. See, it has been found that vestibular exercises, not only general physical therapy, vestibular exercises, they help you achieve habituation to vestibular motion stimuli for visually induced symptoms, space motion discomfort and all, they are reduced by that, and it ameliorates intolerance to moving visuals. All migraine patients and vestibular migraine patients, they have an intolerance to moving visuals. You show them a moving things, then they start feeling intolerance, and that leads to headache. And vestibular exercises achieves habituation to visual motion stimuli, and that helps migraine patients in a very, very big way. So vestibular exercises have got a big role. Vestibular exercises, it helps to correct postural stability, which is very commonly jeopardized in patients of vestibular migraine. Vestibular exercises restores confidence, attenuates headaches too. I'll show in the next slide that by doing just vestibular exercises, not only does the vestibular symptoms improve, but also headaches come down. It is strange, but there are studies which have shown that just by allowing the patient to do vestibular exercises, the headaches of migraine patients can also be reduced. There are peer-reviewed excellent RCTs on this. Then vestibular exercises are also effective as a standalone therapy and also in combination with pharmacotherapy for vestibular migraine. So if you are giving the patient drugs for vestibular migraine, combine vestibular exercises with it and the results will be much, much better. See, all references are given over here. So it has been found, it has been there in this. This is the reference, Sugai et al. They have shown that just avoidance of caffeine stopped vestibular migraine in 14% patients. Just avoidance of caffeine, that stopped vestibular migraine in 14% of patients. In our experience in our clinic at Vertigo and Deafness Clinic, in the last 5 years, we have found that lifestyle modification, vestibular physiotherapy, and avoidance of food triggers for 3 months stopped vestibular migraine attacks in as much as 53% of 486 patients in whom we had not given any drug. And there was more than 50% improvement in 64% patients with just combination of lifestyle modification, vestibular physiotherapy, and avoidance of food triggers. So what I mean to say is that this non-pharmacological therapy has got a very big role to play, and never undermine the role of vestibular of non-pharmacological vestibular exercises. This is the article by Sugaya. You can refer to it, and it has been shown that there is improvement in dizziness followed by vestibular rehabilitation, and it was associated with improvement also. It was also associated with improvement of headaches more prominently in vestibular migraine patients compared with comorbid tension type headaches. So in patients who did not have vestibular symptoms, only had headaches, in those patients also the vestibular exercises reduced the incidence of headaches, and in patients of vestibular migraine both the headaches reduced as well as the vestibular symptoms reduced. So this is the beauty of this study, and that is why we stress upon vestibular exercises in patients of vestibular migraine. So vestibular migraine exercises contributed to improvement of headaches, which is the most surprising thing, both in patients of vestibular migraine and also in patients of dizziness and tension type headaches. It caused an improvement of dizziness, and it caused an improvement of psychological factors, which has been calculated in this study by HIT6, DHI, and the hospital anxiety depression score. So see, this is a extremely well conducted level A study which has shown this. So the non-pharmacological treatment for the photophobia and phonophobia, we ask the patients to use the FL41 optical tint indoor sunglasses and also the Vibes earplugs that reduces the sound. So you can go into the website and get the details of this. These are all available in India also. Now, coming to the pharmacological treatment of vestibular migraine. Now, indication, the medications for where do we use medications for vestibular migraine? We use medications for three things: aborting an acute episode of vertigo or headache in vestibular migraine, which is called event management or rescue treatment. Then we use medications for prophylaxis of vestibular migraine, and we use medication for treating the comorbidities of vestibular migraine. So there are three places where you can use drugs: aborting an acute attack, preventing vestibular migraine attacks, the frequency and intensity of the attacks, and for treating the comorbidities. So these are the three ways. First, we start with treatment of an acute migraine episode, which is also called abortive therapy, event management, or rescue treatment. Now, the drugs for aborting an attack of vestibular migraine, where whatever drug you are giving, remember three things. It has to be administered at the onset of the attack. Don't wait till the attack has fully started. Give the drug immediately at the onset of the attack for it to be effective. Remember that single dose usually suffices, and it must be discontinued immediately after the relief. So if you have given the patient something like prochlorperazine or meclizine, then use it for one dose only. After the vertigo subsides, don't go on continuing with the meclizine or the cinarizine or the prochlorperazine. So single drug suffices. If the patient has got headache, one dose of naproxen or ibuprofen should suffice. You don't need to continue giving the drug. So always know that for aborting an acute attack, a single dose usually suffices. And three is that the same medications are used as for aborting any attack of vertigo or from any cause, whether it's due to migraine or it is due to vestibular neuritis or it is due to Meniere's disease. Those are the same drugs are used. What are the same drugs? Prochlorperazine or dimenhydrinate or meclizine or cinarizine. So these are the drugs that are used to give to for aborting an attack of acute vertigo in vestibular migraine. In our clinic, what do we do? See, if the patients are serious, then in our clinic, we ask the patient to use this combo: 2 tablets of dimenhydrinate, which is marketed in the name of Gravol, 50 milligrams to swallow and then suck. 1 tablet of clonazepam, I'll tell you why clonazepam, and 1 tablet of prochlorperazine, 5 milligram. If the vertigo and vomiting persists after 30 minutes, then injection of prochlorperazine 12.5 milligrams IM stat with 1 tablet of promethazine 25 milligram. If headache, then we use 1 tablet of naproxen 500 milligram or ibuprofen 400 milligrams plus 1 tablet of zolmitriptan 5 milligram or nasal spray if there is vomiting. So this is what we follow in our clinic, but this is for a severe attack. Otherwise, just 1 tablet of naproxen for the headache or ibuprofen for the headache or 1 tablet of dimenhydrinate suffices. But if it's a severe attack, then this is what we need. But we usually try to combine clonazepam with it. Why clonazepam? I'll tell you now. The treatment for an acute episode of vestibular migraine, the abortive therapy and the rescue treatment, the recommended drug options are these. You can use any of them. Benzodiazepines like clonazepam or diazepam, antihistaminics like meclizine, sinerzine, dimenhydrinate, antiemetics like promethazine or prochlorperazine, ondansetron or scopolamine, analgesics in case of any concomitant headache, naproxen or ibuprofen, triptans like rizatriptan and zolmitriptan, and corticosteroids. It is only in cases of status vestibular migraine where the vestibular migraine continues for more than 3 days. That is known as status vestibular migraine. I have had 2-3 patients only, and there we have used corticosteroids with wonderful results. Otherwise, don't use a corticosteroid. So these are the different options available, and the underlined ones are the ones that are safe in children. In children, you can use clonazepam, dimenhydrinate, prochlorperazine, or zolmitriptan. Or for the headache, you can use ibuprofen. These are the only ones that are recommended that can be given safely in children, depending upon the age. The best drug for acute episode of vestibular migraine is benzodiazepine. Why? Because of these reasons. It is agonistic to inhibitory neurotransmitter GABA. It increases the efficiency of GABAergic synaptic inhibition. GABA, is a inhibitory neurotransmitter, and it decreases hyperexcitability of the brain and decreases neurotransmission. Hyperexcitability of the brain and increased neurotransmission is the pathology behind migraine, and so GABA reduces that. GABA inhibits that, and benzodiazepine is an agonistic to the neurotransmitter GABA. Then the benzodiazepine, that is clonazepam, decreases the cortical spreading depression, which is the cause of migraine. It facilitates the GABA activated cholinergic channels, causing hyperpolarization and thus decreased firing rate of the first and second order neurons of the central vestibular pathways. It enhances the pain threshold and therefore reduces the headache, if any. It is a labyrinthine sedative and hence inhibits the vestibular nuclei and hence reduces vertigo. It is also an anxiolytic and reduces the concomitant anxiety. So you see, benzodiazepine, that is clonazepam mainly, helps in so many ways. So whenever you're treating a patient of acute episode of vestibular migraine, whatever drug you use, add clonazepam to it at a low dose. Treatment for acute vestibular migraine episode, triptans. You will all ask that since you can use triptans in acute headaches, why can't we use triptans over here? Triptans have not been found to be very effective. And if there are headaches, you can use sumatriptan, rizatriptan, or zolmitriptan. But in vestibular migraine without headaches, there are RCTs, randomized controlled trials available only with rizatriptan and zolmitriptan. But these are not very large studies. And with rizatriptan, 10 milligrams, it has been found that 15 out of 25 patients improved in motion sickness only, but no improved in more complex vestibular symptoms. Zolmitriptan, 38% improved versus 22% of placebo. So these are the only 2 triptans which have been tried through RCTs. There are randomized controlled studies only for rizatriptan and zolmitriptan, not for any of the others. And there also, they have not been found to be very effective. But you can use zolmitriptan. Then we come to prophylactic pharmacotherapy of vestibular migraine. When to use prophylactic pharmacotherapy? Indications for prophylactic pharmacotherapy are, there are 2 or more attacks per month, or disability lasting 3 or more days per month, or there is failure of or contraindication to acute treatment. That means you cannot use any of the acute treatment drugs. Or using abortive treatment is required for more than once a week, because those drugs which we use for abortive treatment is best not used very regularly. So these are the only conditions where you can use prophylactic therapy. Then avoidance of known migraine triggers. Whenever you are using pharmacotherapy, for prophylactic pharmacotherapy, you have to know that avoidance of known migraine triggers must be there. Lifestyle modification must be followed diligently, and the vestibular exercises have to be done. Prophylactic pharmacotherapy is instituted only when adequate trials at least 3 months with lifestyle modifications, exercises, and trigger awareness fail to contain symptoms. Otherwise, don't jump into pharmacotherapy for prophylactic management immediately. First, try out the non-pharmacological therapy for 3 months. Then, if you find that it is not adequately helping, only then you can go in for drug therapy. Prophylactic pharmacotherapy of migraine, these are the different types of drugs used: beta blockers, propranolol, metoprolol; calcium channel blockers like flunarizine and verapamil; antiepileptic drugs like topiramate, divalproex sodium, or lamotrigine; tricyclic antidepressants like amitriptyline and nortriptyline; selective serotonin, norepinephrine inhibitors, SSRIs and SSNRIs; sertraline, VENLAFLEXIN and desvenlafaxine; Neutraceuticals like butterbar extract, feverfew, and other agents like acetazolamide, magnesium, cyproheptadine, and pizotifen. The underlying drugs are safe in children if prescribed in the correct dosage. That means in children you will have to limit yourself only to propranolol or flunarizine or topiramate. But magnesium, cyproheptadine, and pizotifen can be used in children. So we have got so many drugs. So how do you choose a drug? On the basis of what? In a patient of vestibular migraine has come to you, how do you decide which drug to use and how many drugs to use? There is so much of options available. So how do you decide on the drug therapy? Skip this. So prophylactic pharmacotherapy of vestibular migraine, which drug and how many drugs? See, there are certain principles. No studies show superiority of any one group of anti-migraine drugs over another group. Don't think that anti-epileptic drugs are in any way better than, say, beta blockers, or that calcium channel blockers are in any way better than beta blockers. So no studies have shown that there is any superiority of one group of anti-migraine drugs over another. So do not go by that this drug is a better drug. The drugs are selected on a completely different parameters. We'll come to that. Choice of drugs is usually based on comorbid condition. That means whether there is hypertension, if there is anxiety, asthma, depression, PCOD, glaucoma. On the patient profile, that is if the patient is obese, underweight, if the patient is in childbearing age. On these conditions, we determine which drug to use. As I said, no group of drugs is superior than another group of drugs. Then drug therapy, that means dosage and number of drugs to be titrated on response to the chosen therapy and the tolerance or adverse effects on that particular patient. And poor response to one drug does not mean that diagnosis is wrong. Drugs from another group must be tried. Supposing a patient of vestibular migraine has come to you and they have started topiramate, and you find that if the patient is not responding, don't think that your diagnosis is wrong. Then try with either a calcium channel blocker or a beta blocker, or with a or with an SSRI. So that is how these things work. Everything which I am showing you is referenced. All the references are given here. Principles for prophylactic therapy of vestibular migraine. Again, combining two drugs from the same group is always to be avoided. Don't use two anti-epileptic drugs. Don't use topiramate with divalproex sodium. Don't use two beta blockers like flunarizine and verapamil. So don't use two drugs from the same group. Then combining two drugs from two groups does not necessarily improve treatment. It has been found that effect of topiramate with propranolol is the same as that of topiramate alone or propranolol alone. So combining topiramate with propranolol is not going to give you any better result. Best is to start with one drug only at a lower dose and then slowly titrate the dose as per patient response. And patients may respond to one drug, but after some time the efficacy is found to decrease in spite of increasing dosage. Change to another group is usually beneficial in such cases. So these are the principles that you have to follow. So this is just one study to show you that propranolol and VENLAFLEXIN for vestibular migraine prophylaxis, a randomized cortical controlled trial. It showed that Venlafaxine and propranolol show equal effectiveness as prophylactic drugs for ameliorating vertiginous symptoms in vestibular migraine. However, venlafaxine may be superior to propranolol in ameliorating depressive symptoms. So combining venlafaxine and propranolol did not give any extra result. You can use either propranolol or venlafaxine. If the patient has got some psychogenic symptoms also like anxiety, etc., then of course giving venlafaxine would be a better choice than propranolol. So don't try to combine drugs and think that you will be getting a better result. Now, drug selection based on patient profile. How do you select the drug? If the patient is obese, then you should avoid flunarizine or propranolol or the tricyclic antidepressants like amitriptyline. In that case, in an obese patient, select topiramate. If the patient is skin and leany, avoid topiramate as it will decrease body weight. And in that case, you can select something like amitriptyline or flunarizine. If the patient has got dementia, many patients of vestibular migraine also have dementia if you take a history. You'll, in that case, avoid topiramate and try any of the other drugs. If the patient has got glaucoma, don't use topiramate because topiramate can increase glaucoma. Use some other drug. If the patient has got any hypotension or bradycardia, avoid propranolol and use something else. If the patient has got mental depression, avoid propranolol and flunarizine. You can use a drug like venlafaxine or desvenlafaxine. Female in childbearing group, avoid divalproic sodium and if possible also topiramate. You can select a drug like propranolol or flunarizine. If there is a hepatic disorder, avoid divalproic sodium or sodium valproate and you can select a drug like topiramate or lamotrigine. If patient is on other drugs, for other diseases, then drug interaction must be checked because most of the drugs interact with a lot of other drugs also. So drug interaction must be checked before any migraine prophylactic drug is given, and you can check it from www.drugs.com. So you can check the drug interaction, ask the patient what drug the patient is taking, check drug interaction from www.drugs.com and then prescribe the drug. So contraindication is specific age groups. But topiramate is contraindicated in patients of glaucoma, in patients of kidney stone, in patients of chronic kidney disease, in memory loss, and in depression. Divalproic sodium is contraindicated in young females, high ammonium levels in blood, liver disorders, and in depression. Flunarizine is best avoided in obese patients, in patients of Parkinson's disease, in patients with extrapyramidal disorders, and in patients of depression. So you see, you select the drugs on this. The causes of failure or non-compliance to therapy. When you prescribe a drug, you'll find that in many patients, the patient is not compliant with it. Why? Why is the patient not compliant with it? Improper dosage or causing intolerance, persistence of the disease. It means that the dose needs to be titrated or escalated or reduced in smaller steps. Do it in smaller steps. So if there is intolerance or persistence of the disease, titrate the dose. Most of the drugs are pretty costly. So try with a cheaper drug. There can be adverse effects like weight gain, anorexia, palpitation, depression, drowsiness, constipation, and dry mouth. So you have to then change the drug. There can be lifestyle changes and avoidance of triggers not being followed. So always counsel the patient, whatever drug you give, lifestyle changes, avoidance of triggers, and exercises must be there along with the drug. So if these are not there, then that can cause a failure of therapy. And so counsel the patient again. Addressing comorbidities, the mood disorders, they have to be treated by this, or MARD means migraine anxiety related disorder. So it will require psychiatric or psychological referral, counseling, and antidepressant therapy. If there is persistent interictal dizziness, additional space motion discomfort, a lot of these vestibular migraine patients have it, they have to undergo vestibular rehabilitation therapy, especially the eye exercises. If there is motion sickness, then premedication with meclizine or dimenhydrinate or benzodiazepines before undertaking a journey. Treatment of MARD, depending upon the symptoms, you select the drug. We are not going into the details of that, lack of time. Adjuvant therapies or Neutraceuticals, these are the ones that can be used. Riboflavin, magnesium, butterworth extract, coenzyme 10, Q10, and vitamin D. These are the ones that have been found. Out of them, the best is magnesium, 600 milligrams per day, which you can definitely prescribe to your patients of vestibular migraine. Non-pharma, then we come to the last part, that is neuromodulation. It has been proven to be effective. Neuromodulation has been proven to be effective in classical migraine. This is one form of non-pharmacological therapy where we are giving an electrical stimulation to the patient, and not only an electrical stimulation, we are causing a neuromodulation. And it has been found to be very effective in classical migraine. So if it is effective in classical migraine, so why should we not try it for vestibular migraine also? Neuromodulation is the functional modification of neural circuits within the non-pharmacological stimuli delivered non-invasively or by implanted devices. There are implanted devices also, or some devices you can give present from outside also. Devices used for neuromodulation use electrical current or magnetic fields or caloric stimulation to modulate signaling activity in the brain. It is used both for rescue therapy as well as for prophylactic therapy in classical migraine. Though not yet considered as first-line treatment, some of these non-invasive forms of neuromodulation have been approved by FDA for classical migraine and for cluster headaches. So these are approved products. So non-invasive neuromodulation therapies for migraine and cluster headaches are a practical and a very safe alternative to pharmacologies. What are the different types of neuromodulation available? The proven efficacy in classical migraine. It has got a proven efficacy in classical migraine. So why not try it for vestibular migraine also? These are the different processes available: transcranial magnetic stimulation, deep brain stimulation, supraorbital nerve stimulation, sphenopalatine ganglion stimulation, occipital nerve stimulation, and vagal nerve stimulation. They have been successfully tried in classical migraine and in cluster headaches. Other forms are neuromodulation by repeated caloric stimulation has been tried in migraine, but no reports are available in vestibular migraine. External trigeminal nerve stimulation, it is called E-TENS. It is found effective in rescue treatment of vestibular migraine. So these are, if this E-TENS, it is another very good thing. So if classical migraine and vestibular migraine share the same pathomechanism, and if the same drugs work for both classical migraine and vestibular migraine, then neuromodulation should also work for vestibular migraine too. So let us try it out. Let us work in conjunction with a neurology colleague. And these instruments, I'll show you the instrument, they don't cost much. Anything between 10,000 rupees to 30,000 rupees. See, these are the different devices available. Transcranial stimulation by spring TMS. This is spring TMS. Vagal nerve stimulation by gamma core or electrocore. Stimulation in left and right supraorbital or supratrochlear nerves by Kefali. This is Kefali. This has been used. This is the only one that has been used in vestibular migraine with very good outcome. And this is the reference. Bay has used it, and it is published in the Journal of Neurological Science in January 2020. This is called Kefali. This has been used, found to have very good effect in vestibular migraine. Peripheral nerve stimulation by nervomigration. These are the different types of devices that are used. Now, what is the protocol that we follow in our clinic? This will take a bit of time, so I am skipping in this portion. We follow this, and we have got excellent results in vestibular migraine. And this is our results, just to show that, basically to show that what excellent work we do, forget it. But then the point is that this is how we do, and we have got very good results using that protocol that we follow. Now, let us not forget, this is the last slide, that regular follow-up, re-evaluation of outcome and dose titration is mandatory at 3-month intervals in all patients of migraine. And your goal should be more than 50% reduction in attacks. It is a reasonable goal. Patient to maintain a very detailed diary of vestibular and headache events. Migraine and vestibular disease, especially Meniere's disease, can coexist. I believe Dr. Isha has stressed on it and driven it home very, very well. Comorbidities to be paid extra attention. Detailed history taking is essential. This, I believe, also Isha has stressed very well. We must support randomized clinical trials in vestibular migraine for better treatment options for our future patients. Not much of randomized classical clinical trials. Not much, not at all. RCTs are available for vestibular migraine. And newer treatment modalities like neuromodulation by non-pharmacologic modalities must be tried in vestibular migraine. So thank you.